the last speaker for the day today is our hero, Dr. Satanshu Mathur, who's been the chief instructor of the course, and we've been doing this course successfully for the last 5 years in all India. Yeah. So, and he's going to talk about IOL exchanges, the various methods of getting the IOL out. So over to you, Satanshu Mathur, and we've all been trained, and you all know about his SSTC and his interest in training and teaching everybody. So, you ready, sir?
Well, so what Dr. Rajendra Prasad has said, this is make a hole and then extend it. Dr. Kamal has said without extending the making hole, you can make hole with the simple 26 gauge needle, which we all are doing for last so many years. So my topic is IOL exchange, why it is important. Once upon a time when we were studying, we had never thought of IOL implant because we were learning IOL implantation. That was difficult for us 30 years back. But at the time for till our practice for up to 5-6 years back, we will never thought of explanting the IOL because it was not easy job. Nowadays, everybody wants 6x6 vision. Our time was when it was there refractive error residual +3, -3, patient happy with the glasses. But now, this is not the scenario. Everybody wants 6x6 post-operatively and they are refractive surprise also. What are the indications for the IOL implantation? So their indications are, number one is the IOL power wrong calculation, unhappy patient because of the multifocal lenses, the rings, shadows, dislocation of the lens, and damage to IOL haptic during the insertion. So there are many things that causes, this is the lens, this is operated almost 30-40 years back somebody. This is totally opaque lens. Patient has 6x36 vision. I don't surprised to see even 630 how is there. So we have no option but to remove this lens. There are many techniques, but the simplest technique which we are going to show you is the scissor. This is known as IOL cutting scissor, available with all the medical labs companies here. We have to just do two things. Dislocate the lens from the back into the antechamber. Because operated 30 years, 40 years back, so there are a lot of adhesions there. We have to remove all the adhesions by the viscoelastic. You see, condition of posterior capsule, so much opacification also there. So we are removing the lens, slowly injecting viscoelastic behind the lens and over the lens. We have to protect the posterior capsule. We have to protect the cornea also. Once the lens is into the antechamber, we have to remove it. We want to remove it from the 2.8 millimeter incision without giving any stitch. If we have to enlarge the incision, no issue. So see, this is scaffold lens. We are injecting behind the opaque lens to protect the posterior capsule. This is 3-piece lens we are injecting because we don't know the condition of the posterior capsule. You have to use lot of viscoelastic to protect the endothelium and the posterior capsule. Incision is 2.8 millimeter only. Stitchless. So one instrument is holding the lens, and this IOL cutting scissor is just make a cut up to the center of the lens. This is enough. Hold the lens and pull it out. The cut end which acts as a fulcrum over the incision side, and you can rotate the lens and it will come out from the 2.8 millimeter incision very easily. Not to enlarge incision. Otherwise, we have to enlarge incision to up to 6 millimeter. So this lens is out. So this is the way we can manage the IOL. And already lens has been implanted, so it is okay. There's another situation which I have just talked to you is the broken haptics during the. You see, when we are injecting the lens, especially in the Indian hydrophobic lens, cartridge are not so good, so their haptic is broken with viscoelastic is less there. You see, there the haptic is broken. If you leave this haptic, lens is going to dislocate someday, और आपका colleague जो होगा बाहर से बैठा, he will say ये टूटा हुआ lens डाल दिया है. So to save yourself, you should not leave this lens inside the eye, but you should take it out. So if you leave this inside, you have taken out the haptic. If you leave the lens inside, it is going to dislocate one day, no doubt. So this is hard lens, we are just supporting with the other instrument for the side port and cutting through and through, because hydrophobic lens, difficult to cut. So we have cut in two pieces, we will hold one piece and we will remove it. Simple forceps are there to help us to remove the lens. In this way, you can remove the other piece also. Third case I want to show you a third case. This is a case, already lens implanted in this case. There is a one more technique to use, which is, they are capsules technique. Previously when we were using IOL, there was no injector. You will not believe it. This case 3. When we were doing this started IOL, there were no injectors. So we had to have a forceps that was known as capsule holding forceps, through which we were removing the lenses. So not to cut the lens, just press by the one iris spatula from the behind the lens. From the behind the lens, we are just pushing the IOL up, so they make a fold over it. And the forceps on the two sides, they hold it, fold it, and then you can take it out from 3.2 millimeter incision. So there are different techniques, whichever you like, you can use it. But if you have IOL cutting forceps, that is more convenient. So I request all of you to have one IOL cutting forceps in your library.